So we hope that has set the scene to some degree around some of the issues related to revalidation. We asked our panelists not to specifically go into the details of the individual systems, and the planners of this conference felt that one of the best persons that could help us look at perspective internationally of revalidation was Professor Liz Farmer, not only because of her perspectives from her past work in Health Workforce Australia, but because of her a number of reviews that she's done on both regulatory issues such as performance assessment and revalidation. And Liz is going to talk to us about the evolution of continuing professional development towards revalidation, looking at it from an international perspective.
Terrific, there it is, wonderful. Thank you very much indeed for that kind introduction, and may I say what an honour and a pleasure it is to speak with you this morning about revalidation and the evolution of CPD towards revalidation. I'm going to concentrate on the international perspectives, hopefully pick up some of the threads that we've heard in this morning's fabulous panel discussion, and also come to some summary. I'd just like to begin by acknowledging the traditional owners of the land and pay respect to their elders, past and present. So we've had a bit of discussion this morning about terms and concepts, so I just want to go back over that just to clarify some of the difficulties that we have in speaking about revalidation, recertification, and CPD. And then I'm going to try to situate the international practice in 4 frames of assessment so that we can get a bit of a pen picture or a conceptual map of where other countries are actually working and what they're actually doing. And then finally, I'll just come to some brief conclusions. So for those of you that haven't been part of the last couple of days, very quickly, competence, performance, and outcomes. So competence is what a doctor is deemed capable of doing. Performance is what a doctor is actually observed to do in their professional, everyday professional work. And outcomes are such things as indicators of health status of patients. Now, we've heard a bit of discussion today about CPD and CME and so on, and I just want to unpack that a little bit. You could say that CME, is education that's focused on currency of knowledge and maintaining your knowledge and being up to date. CPD, however, is a completely different ballgame. It certainly and usually contains CME, but as we've heard, it usually contains other aspects. They may be learner-centred, there may be practice-based activities, there may be a framework, there may be categories, there may be points, there may be other kinds of structures that colleges place around CPD as they define it, and indeed it may include activities such as audit or analysis of patient outcomes. However, regulators, colleges, training programs do use these terms differently, and what is said to be CPD in one college is not the same as what is said to be CPD in another college. So because of this lack of common terminology, and because everybody loves to have a different way of calling their own particular CPD program something else, we have an explosion of 3-letter acronyms to describe all the different things that we're doing. And so in order for us to have a really solid debate about CPD, we must drill down to the actual detail of what CPD means in any individual setting. And preferably, if we're to advance this dialogue and understand each other clearly, we actually need a common language that we can agree on, we can then use in order to really understand what it is that other people are doing. So I'm going to turn to 4 frames of assessment. This comes from Dan Klaas, the reference is there, to try to describe the way in which this whole process of CPD and the move towards revalidation, recertification has been occurring internationally. Now, these are Dan Klaas's 4 frames, and you will see that he places at the top the frame that we are very familiar with in medical undergraduates, which is pre-entry to the profession, and we assess their competence, we assess their readiness to progress into the intern year. The second frame is CME in practice, during practice, we infer competence because the doctor undertakes CME. CLAS then says there's another frame, which is the actual assessment of performance in professional practice. And then finally, again in practice, there is the measurement of outcome indicators, audit, and other related activities. And you'll see that on the top right-hand side of the slide, CLAS says that number 1 and number 2 are effectively proxy indicators, whereas number 3 and number 4 are potentially actual indicators of what a doctor does. So if we look at revalidation, we can see that we are largely, but not entirely, and I'll come back to this later, looking at frames 2, 3, and 4. Now, frame 2 CME, I'm not going to dwell on. I think everybody understands it, and we've said that effectively, by keeping oneself up to date is important, but again, it only infers that the doctor is competent. But however, if we turn to frame number 3, which is assessing performance, we can start to look at some different approaches that have been used in other countries. Now, in a short talk, I can only pick certain examples. I cannot be completely comprehensive about what goes on in each country. So I'm going to very definitely pick out certain highlights. I know that some of you have heard about some of these things already in the conference, so I'm not going to go into them in detail. And I know that later on we are going to hear more about them today. But I'd like to start by talking about what's called the MEPP model. And this is a Canadian model that came about around 2000. And I'd like to, the reason why I've put that language in orange is I'd like to point out the educational language of the MEPP model. So it's the maintenance and enhancement of professional performance. So it's a very much an educational language, and that is very much how Canada has approached their issues in terms of thinking about how do we maintain and enhance professional performance. Now, this is the actual model. I'm not going to go into it in a great deal of detail, but what I want you to see about it is that A, it looks like a wedding cake. And indeed, it's supposed to look like a wedding cake. The point is that the first step, and we've heard this echoed today in the panel discussion, the first step of the MEPP model is very much an educationally focused, personalised, peer-orientated, explicit model. And I want you to notice the word at the bottom. This word is feedback. There it is. I'm going to come back to feedback throughout. Now, we've heard that, today one of our regulators saying, well, you know, if you do multi-source feedback, how many doctors actually go on to something else? Well, what they go on to is the second step of the MEPP model. The idea is that you can pick those doctors up earlier and you can support them and return them back to a higher standard, an acceptable standard of practice more easily because they're early identification. Then finally, right at the top of the model is the doctor at high risk of underperformance for whom something else needs to be done. Now, sitting within that MEPP model then, and on the bottom layer of the wedding cake is this concept of monitoring, feedback, and enhancement. And I'm just going to pick a couple of examples of how Canada has approached that. So firstly, in Ontario, the College of Physicians and Surgeons in Ontario have a program called Random Peer Assessment. Now, they have around, I'm told, around 3,900 doctors. And this applies if you have been in practice over 5 years and or compulsory if you're over the age of 70, which means that about 500 to 600 doctors a year are approached to participate in a peer assessment, and it is compulsory if you are approached. This involves objective information obtained by a peer visitor who comes to your practice, reviews your record, and has a discussion with you. Very importantly, because of this issue of scope that we've already heard about, the peer reviewer is matched to the practice of the doctor concerned, and that's really important. And again, then, that trained peer is able to assess against a standard for regulatory judgment. So this is kind of what Ontario peer assessment looks like. It's a performance-based assessment. It sits in Dan Klass's third frame. It's only one peer, records, and usually a discussion enables some kind of decision point to be reached. And we've heard the vast majority of doctors, after half a day doing this process with a peer in a collegial environment with feedback, are found to be performing, according to this method, perfectly well. Does it work? Well, I won't go into detail, but there has been a recent systematic review on the value of peer assessment, and basically what it shows is that it is more effective, it's continuous, that is over a period of time, you have a number of these, and importantly, feedback is given. Now turning to Alberta, Alberta's done something a little bit different, and we have in the audience one of the world's experts in multi-source feedback, and I know Professor Lockyer is going to be talking later and has been already talking about the Physician Achievement Review. It's a form of multi-source feedback, which again we've heard a bit about in the panel. Basically what happens is that 3 different groups give feedback on the doctor by questionnaire: colleagues, co-workers and patients. The numbers there represent the sorts of numbers you need, so you can see that they're quite small. And so these kinds of approaches, multi-source feedback, such as used originally in PAR, have high feasibility. They're cost-effective. I saw an estimate in the literature of $40 Canadian per year. They enable triangulation from multiple observers who must work with the doctor on a regular basis. That's very important. The doctor self-evaluates, and very importantly again, feedback. Peer-assisted reflection is important, and again, Jocelyn Lockyer has written extensively about this. One of the few methods where you can actually have patient views, and I know we've got Michael Greco in the audience somewhere who specialises in this whole process, and particularly in using patient views. And low performers can be referred to step 2 of the wedding cake. So this is what it looks like. It's spreading. PAR Alberta was very much the pioneer. Now Manitoba, as we heard earlier, is also introducing PAR, or has introduced PAR, and both of those jurisdictions identify potential underperformers. However, Nova Scotia PAR, who has taken it up more recently, and the Council of Academic Hospitals of Ontario, definitely state that it is not for underperformers. So if we just summarise the MEPP and the follow-on of MEPP in Canada since the 1990s, we can see that includes CME, but it also includes a very heavy emphasis on Klass's third frame, among other things, and we're also hearing today that that is broadening as we speak. I think another thing which we're going to hear about later is also assessing performance is going on very actively in the undergraduate and the early postgraduate space. There's a very significant shift in education in this space. I know we're going to have speakers talking about this, so I won't dwell on it. But workplace-based assessments such as mini-CX, case-based discussion and multi-source feedback are now becoming tools which are being used in these spaces prior to obtaining your fellowship and then going on to, if you like, the revalidation arena. Now, we've heard the UK made a giant leap, but they've made it on the basis of a very sound approach. The sound approach is good medical practice. This is just a diagram of good medical practice. There are 4 main components of good medical practice, and you can see what they are. And within each of those main components, there are 3 items. And so the GMC, I'm looking for a nod from Peter Rubin. Thank you, a nod, that's very good. The GMC started with something that was a foundation agreed and caucused through the medical profession as what they deem good medical practice. Now, I'm just very quickly take you through what it looks like for those of you that are not aware. A doctor comes along with a pile of supporting information, which I'll describe in a minute. That doctor has 5 appraisals, 1 every year. and assuming that those appraisals based on the supporting information are suitable, then this very important person that Peter has already mentioned, the responsible officer, makes a recommendation, and that recommendation goes to the GMC, and the GMC determines whether they will accept that recommendation or not. And we've also spoken about the absolutely pivotal role of the medical Royal Colleges and faculty in that process. Now, what I would like to point out to you in this process is this position about appraisal. Appraisal is based on a personal development plan, and it's based on a collegial relationship, and preferably over time. And so this gets back to some of those concepts that have been coming through the Canadian model, where the importance of feedback, the importance of a longitudinal process has been demonstrated in the literature. The other thing that I'd like to draw your attention to is the portfolio of information that the doctor provides in the UK, usually electronically, and it sits in all three of Dan Klass's frames. And if you look at it then in terms of the diagram, you can see that yes, there is CME. In terms of performance in practice, there's colleague and co-worker and patient feedback. There's also a review of significant events and complaints and compliments, and there is also a quality improvement activity. Not all of those things done every year, but they're done over the period of time. So the approach that's being taken by the UK, and indeed it's very similar to the approach that's been taken by New Zealand, which I won't speak about because I know you're going to hear about it later, is that it goes across all three frames of Dan Klass's 4 frames of assessment. Now, I'm going to mention the USA very briefly because we haven't heard from the USA today on the panel. The USA, as you would be aware, a very large number of doctors, about 800,000 doctors in 24 member boards. And if you are board certified, then from 1990, you're required to go through a process called recertification. The reason why I've put certification in red there is I just want to point out to you the language. The language is moved from the Canadian language of maintenance and enhancement and performance to a regulatory language, if you like, which is certification. And those are the 4 things that you need for certification. And I'd like to point out 2, 3, and 4. If you have a look in terms of Dan Klass's model, this is the only jurisdiction where examinations still form part of this process. And what happens is that every 10 years, a practicing doctor is required to sit a secure examination, such as a multiple choice test, under test conditions. And in some specialties, it is limited. So, for example, in surgery, you can only take it between years 8 and years 10 after you've become board certified, and you must pass it. So that's an interesting difference from the United States. What else do they do? Well, they have a heavy program of knowledge self-assessment, which I guess I've largely placed under CME. They have practice audit and improvement exercises relevant to your specialty, which clearly is in area number 4. But they're not heavy in performance in practice. So I'll finish up by just talking about the main trends if we just take that very quick pen picture of those different countries. Firstly, I think we're moving well beyond CME. We're interested, as Joanna Flynn said, in the right touch approach. What is the right touch approach? And this is the big question, I think, for Australia at the moment. If we look around the countries, there is significant variation in the way that revalidation, recertification, and so on is carried out presently. But what we're seeing is a strengthening and a broadening of existing approaches. These approaches from different starting points, but in a way they're tending to converge slowly and more rapidly in other countries such as the UK. Countries who have uniform national legislation or have moved to it usually have a more programmatic level of assessment with assessment in multiple frames, but there are many countries who are considering moves to a more uniform national legislation, and certainly this has been called for by the Federation of Medical Regulatory Authorities in Canada, that we need to think about moving from a jurisdictional setting to a more uniform national legislation. Shared accountability, I think, is a very important concept here. This means that it's, and we've heard this in the discussion, it's not just about the doctor and it's not just about the employer. It's about the entire health system and how does it work in all the different myriad representations of the health system. And it also is about patients, because if we use multi-source feedback and other methods to gain patient input, there is an accountability from patients and also from co-workers who work in healthcare teams with doctors. And finally, evidence points very much to whatever method you use to the importance of feedback. Finally, the dual aims of revalidation are primarily improvement, and not always underperformance, but mainly underperformance. And I'll stop there. Thank you.
Thank you very much. Questions before our morning tea? Thank you.
Martin Richardson, orthopaedic surgeon in Melbourne. One of the things that came through from your talk there for me was the emphasis on feedback, which I agree is very, very important. What would you suggest as the best way to train physicians, surgeons in feedback? I would suggest there is little in medical school and there's probably little in our CME at the moment that would actually set us up to give this feedback appropriately.
Yes, thank you. I think that's a really important question. We need to do better and we need to be quite explicit that right from the beginning when the medical student enters the health service, wherever it may be, that the supervisor or preceptor is trained in the basic principles of giving feedback. And indeed, the basic principles of giving feedback are one thing, but giving feedback to practicing doctors on multi-source feedback, for example, if it isn't particularly good, or in other areas which have fallen down, is actually an art form and requires a higher level of training. So it's not just basic training for all, it's really training and then taking some of those people who've got a natural ability to give feedback and actually giving them even higher level of skill. So it is a complex issue, feedback, and something we don't do very well. I agree. Thank you.
Robin Mortimer. I'm from the Australian Medical Council. Clearly, these programs that you describe require a program to be set up at the workplace to carry out a lot of this activity. Did you get any insights into how the quality of that program is assessed and maintained? Or is it just assumed that these things will work perfectly?
All right. Yes, absolutely. And I think, I know Professor Lockyer might like to answer this question too. If I take, for example, the Ontario experience, the peer record review, it is a very serious process. Peer assessors are trained and they are particularly giving high-level feedback relating to the previous question. And they're monitored, and it is a program where there is continuous feedback from the assessors about their role and how it's working, and strive to continuously improve that program. Same with multi-source feedback. Jocelyn, I don't know if you wanted to say about training feedback people for multi-source feedback or PAR or whatever.
I would say that's the limiting feature. The physicians who are identified at risk, yes, there's a team that is engaged, and the person who's at very high risk will have office visits and support over a period of time that might be up to a year. But for the rank and file who are doing okay, there's not nearly enough discussion and conversation about how they could use that data to improve their practice.
Right. Thank you.
Other questions? Yes.
As Gareth Phelps, physician and one of those evil medical administrators, I just want to ask about the balance in classes framework, and where you think we should put the balance around performance in particular. And I just observed that whilst our community, the owners of our health system, expect us to be fit for purpose, they expect us to be up to date. What they're actually looking for is what Andrew alluded to, which is the delivery of high quality care. I wonder if we build this with our frame of reference as doctors, we're likely, I think, to head towards the CME part of this, but I wonder whether we should actually be building this with the end users in mind and focusing more heavily on performance. Just interested in your views.
I certainly think it's worth looking at the third frame, and that's performance in practice. We're certainly going to hear more about the New Zealand approach with the practice visits. And we've heard about the Ontario approach with the peer assessment and CPD looking at records, whereas the New Zealand approach is wider than simply looking at records. Other groups have looked, for example, at surgeons working and anaesthetists working and so on. So I think it's worth considering performance assessment in the full gamut of what we do. And that ranges, in fact, from fairly low-cost approaches such as multi-source feedback, which are quite more easily administered on a wide range, to highly cost-intensive approaches such as direct observation, in the practice, in the surgery and what have you. But I think we should look at the whole range of the performance assessment processes before we make decisions.
Charles Guest, I'm a public health physician. Wondering if you could share some experience on the best practice and lessons learnt at the regulator sanctions end of this activity. There's been some spectacular court drama, but where the Medical Council is interacting with the regulator and lessons learnt so far for today, because I see the program is primarily about the medical organisations talking and perhaps less so on the regulator.
Right. As I'm not a regulator, it's a little bit of a difficult question for me, but I think I understand your thrust is that this must be a joint conversation between the various branches of the medical profession and the regulators in order to determine the right way forward. But I wonder if any of the regulators would like to pick up that question.
Doesn't look like it.
No, it doesn't look like. I'm looking hopefully to see a sea of no, I don't think so.
We'll come back to that at coffee.
We might come back to that this afternoon.
Ian Fraser from the College of Physicians. Some medical practice programs now can do sophisticated audits, and for the non-proceduralists, it's very much looking at processes rather than single events. To what extent are electronic medical records going to be seen as a way to quickly or cheaply identify doctors without having to do such an extent of one-on-one practice audits?
Yeah, very interesting question, yes. And we should look at the technology that we have available, and we should look at the most cost-effective way of doing something if we decide we want to do it. And certainly the medical record, the electronic medical record gives us quite a different set of opportunities compared to when these sorts of activities came in the 90s. And so, yes, I think the electronic medical record is important. But it's still a medical record, and it will still be able to maybe access it more easily. But it still should show you whether or not the medical record and clinical reasoning of the doctor is satisfactory or not. But certainly, I think clinical audit in terms of medical record review has a literature. And would seem useful if we could think of streamlined ways of doing it.
The Senator?
Jill Sewell from the Australian Medical Council. In relation to professional practice, how can we distinguish or meld the component or the contribution of the individual doctor with the contribution of the system within which that doctor works? Yes.
Yes. I spent about 3 or 4 days in an international think tank, and 2.5 of those days were thinking with a group of assessment experts about the relationship of the doctor to the team and the system and how you assess them. So there is an article that I can show you which is the best of our thinking. I think it's a very, very interesting issue. Because here we have, for example, if you take somebody who would routinely work in a team, such as a surgical colleague, clearly the outcomes of the surgical colleague are not entirely due to the colleague, they're due to the entire surgical team. So we have to think of ways where we can measure, if you like, or get some handle on whether that surgical team and that surgical colleague are performing. It's a vexed question, it's a difficult question. I could point to some work that's been done in the UK. I don't know if Peter Rubin would be able to speak a bit more about this, but the surgeons are working intensively in this area and have done some work published quite recently about this whole issue of what kind of data can be obtained, particularly from hospital data, in terms of trying to ascertain standards of practice for surgeons.
Do you want to speak to that?
This is really fundamental, and team peer pressure and peer support is obviously one of very important aspects of driving up standards. But the public expects someone to be in charge of that team. The public wouldn't get it if we say, well, actually, it's the team that runs it. No, somebody's in charge. And most times, not always, most times that person will be the doctor. And so we mustn't lose sight of that either. But the teams are crucial. But one would hope that in a functional organisation, dysfunctionality within an individual team would be identified locally and sorted locally.
Yeah, it's Ian Boyd from Medibank. Look, I'm particularly interested in the outcomes measurement, outcomes assessment, and moving beyond just simply measuring process or adherence to clinical pathways, but looking at patient-reported outcome measures, PROMs. Yes. And with particular interest in the work that Michael Porter and others are doing in Harvard from the International Consortium of Health Outcome Measurement, where they're really pushing the idea of standardised sets of measurements on PROMs, which can be used across jurisdictions, across countries, and using that as an indicator of a physician performance across various health settings or health facilities. Do you think that is powerful in this, or does it have a place in this?
I think it has an important place, and I think that if I take, for example, general practice, and if we go back to the earlier question about medical records and electronic data systems, it isn't in fact that difficult to take actual patient outcome data from, let's say, a general practice. I'll just take that as an example. So that, for example, you can look at chronic disease states such as secondary prevention of coronary artery disease, such as diabetes, and you can actually look at patient outcome indicators. And then as a form of an audit process or a continuous QI process, you can work to not only compare your outcome indicators to other like practices, but also then work on how you can improve your indicators so that you're generally improving indicators of, say, diabetic control or indicators of secondary prevention of coronary heart disease. So I think that these form important tools, and this is where we can kind of learn in revalidation from really some other spheres which haven't entered revalidation, have been more about things like the National Primary Care Collaboratives, about quality and safety issues. But there is a place for that body of work to see how we might bring that in to enable a doctor or a team to demonstrate what their, let's say, their chronic disease care outcomes actually are. But I think very important we move away from process. With electronic medical record, we are enabled to do that. We can take a patient's blood pressure straight off the record. We can take their HbA1c. We can take their lipid profile. So there are ways that we can think, I think, quite outside the square, but are manageable for doctors.
I think it can move beyond general practice also into cataract surgery, treatment for benign prosthetic hypertrophy, even into some joint replacements. Asking the patient, can you walk now? Can you see now? Can you do your knitting after a cataract surgery? I think may challenge some members of the profession, but I think it's a place we need to consider going.
Yes, thank you.
Last question before tea.
Thank you. My name is Sarah Dalton. I'm a paediatrician from the Clinical Excellence Commission in New South Wales. It's great to see the international perspective and attention to measuring our performance. I'm interested in how we then improve that performance once we've identified issues, and we've talked a little bit about that, in particular improving individual performance. But I noticed that a number of the activities include practice improvement projects that we're asking our physicians and surgeons to do. So what responsibility do we have in upskilling people to be able to identify and then improve their individual and their practice outcomes?
Yeah, really, a really important question. There was a recent systematic review done on clinical audit. There was also a Cochrane systematic review done around in 2006. And one of the findings was that audit processes are more likely to be successful when they're conducted in environments where there is strong support for the audit process. And where there is institutional responsibility is taken, that's part of the learning culture of the institution, that those who are undertaking audit or looking at patient outcomes not only design good questions, collect good data, but are also supported to actually make change as a result. So there's a big gap between, firstly, the kind of questions that you design and the sort of data that you get, and whether or not that's really suitable. But probably the bigger gap is what you do about it when you've got it. And there, because of the wide variety of settings in the health system, you may be in an environment where this is part of the way that a service does business, but you may not. And the value of clinical audit is probably diminished in environments where you don't have that strong support to close the loop with the clinical audit. And I think we've got a long way to go in ensuring that those who undertake clinical audit in whatever field actually do have that support and knowledge. And that requires time, it requires training, but it also requires a culture change on behalf of the organisation. And it's particularly difficult to achieve in, for example, to take an extreme example, in solo practitioners, because they may lack that support.
Could you join me in thanking Professor Farmer? So we're going to break for tea, and when we come back in 30 minutes at 10:30, I want you back in your seats at 10:30. We're going to talk about, in session 2, how do we actually assess an individual's performance? We'll get into the details, so enjoy tea, and we'll see you back in 30 minutes.